Okay.
Please.
Good afternoon, everyone. My name is Chiara Giovannelli, and I come from Charité Berlin. And I am happy today to bring our clinical point of view, and I'm happy to try to explain why certified planning tools matter in hyperthermia treatment. But first, I would like to start from the basis. So hyperthermia is not an experimental concept. It has been clinically used, and it helps us in numbers of different mechanisms because it inhibits the tumor DNA repair, it improves the perfusion and the blood oxygenations, and it also alters the tumor cell metabolism. Altogether, these mechanisms help us in making it a powerful chemosensitizer and radiosensitizer. It has been used for a number of years and for a number of different tumor specifications. And it is well known for us that it also improves the overall survival by 15% when compared to other modalities alone. Even if it's well known and it's widely used, hyperthermia still lacks certified treatment planning system. And this makes it the only treatment modality in radiation oncology without a standardized treatment planning infrastructure. So why is it that? Because treatment planning for hyperthermia is very challenging. So if we compare it, for example, with radiation therapy, in radiation therapy we can use CT images, and CT images gives us patient-specific information, like, for example, the electron density, which allow us to calculate very accurately the dose inside the patient tissues. This is not possible with hyperthermia. We can rely on CT images only to get geometrical information about the anatomy of the patient and about the tumor position and the size. But for the key input parameters for us, which are the conductivity, the permittivity, and the blood perfusion, we cannot directly measure them. We still have to rely on average values, which are taken from different datasets. And this is a limitation because actually these values are very different across different patients. And this is why we have bigger errors in hyperthermia. But why this is not a big concern? Because, for example, in radiation therapy, we demand submillimeter geometry accuracy because we have a high toxicity risks. So we can damage the organ close to the tumor, or we can have secondary tumor arising. Why this is not the case for hyperthermia. We have a different risk to benefit ratio, and even if we have higher uncertainty, we are not compromising the patient's safety because our side effects are very mild. So the question which naturally arises, why do we need to plan at all? Treatment planning from a clinical point of view are very important because having a fast and reliable tool would allow us to compare different approaches, meaning we can choose the best one for the patient, and this is very helpful, of course. We can also study and test different smart antenna steering to achieve the best tumor coverage and the lowest outpost risk. But also having a fast tool will help us with the online adjustment, because if we have to rely with tools which are not precise and are very slow, it's very hard for us to guide decision during the treatment, and means it's also hard to follow guidelines during the treatment itself. We also have to rely to operators which are very experienced, while having a tool would help us to decrease this variability, and this is very important for centers which do not have such experienced staff. And last but not least, as a researcher, I also think it's important to say that it would help us to accelerate research, because it will help us to enlarge our libraries and to test different scenarios to focus more on scientific discoveries. So what is done today in clinical practice? Today, we rely on so-called quasi-2D models. These models are calculated using different providers' medical product, but these models are based on homogeneous cylinders, so the patient is approximated as an homogeneous, meaning that we are not including any anatomical information at all inside this tool. We are based on fixed transfer slices, and we cannot have any individualized tissue segmentation or any kind of organ-specific modeling. Of course, this is a limitation, because We are not considering the anatomy of the patient itself, so it's not personalized. We are not really able to predict accurately the energy absorption inside the patient because we are not including any heterogeneity in those tissues. And this means that we also can have higher output risk inside the patients, and we are not including any tissues properties. So we are collaborating with Dr. Sennewald in developing Hyperplan, and our goal is to try to close this certification gap. So we would like to go from what is done usually in clinical practice today, which is more or less a blind guessing, to something which is including the anatomy of the patient, which would allow us to include different dielectrical properties, different tissue segmentation, but also to visualize in 3D what's the energy absorption rate inside the patient. This was unexpected. Okay. So Hyperplan is currently undergoing a CE validation process. And the goal is to support personalized deep hyperthermia planning based on a model which is 3D. It's based on CT images. And we also want to accurately calculate the energy absorption rate as a surrogate for temperature. And this is the base for a treatment planning system that is more safe, that's strategy-driven, that reduces the operator across different people, but also across different centers, and that supports future standardizations in our field. In this validation process, we are going step by step, and our first step, we wanted to understand if our electromagnetic solver is accurate. We want to see if the SIR patterns that we are simulating with Hyperplan are really matching reality, and we want to understand if our numbers are really accurate while predicting the SIR. In this presentation, I will mainly focus on sigma I for a number of reasons. So the first one is that it is the most clinically used among the applicators of the BSD family. It is the only one that allows for 3D focusing. But also we realized during the validation process that there is a lack of experimental data about these applicators, and that's why at Charité we conducted a full experimental campaign to acquire those data. Let's start from the algorithm validation. Our solver in Hyperplan is based on a FDDD method, which are the most widely used while solving Maxwell equation in biological media. Following the European guidelines from the Society of Hyperthermic Oncology, we validated it against the state-of-the-art software, which is Sim4Life. In the validations, we consider different antenna settings, we consider different media and different frequencies. And here in this slide, we can see what we simulated with Sim4Life. And here are some results. So what we found, so we can see here on the y-axis the calculation from Hyperplan, and on the x-axis the one from Sim4Life. We can see that our results matched very well, and we were well below the threshold that's allowed of 20%. We never exceed 8%, confirming our solver accuracy. Then, in the second step, we wanted to evaluate the SIR patterns. In this step, we used a phantom, a lump phantom matrix. We consider different steering position, and we compare different parameters. We can see here on the top of the slides the phantom that we used, placed inside sigma I. And at the bottom, we can see how we modeled it in Hyperplan. So we place it accurately inside our applicator, and we also assign different dielectrical properties. Here are some results. So we can see that testing different focus positions and steering, we were able to match very well with Hyperplan what's happening in our experiments. For the numerical validation, we were based on the so-called temperature rise method, meaning that we exploited the SIR formula, which is directly proportional to the early slope of the temperature increase. In this step, we again used a phantom, but before making our experiment, we decided to characterize experimentally the electrical properties. We used a duct-12 probe in order to measure both the conductivity and the permittivity of the phantom material. Then we perform a CT image, and we scan the phantom for direct 3D positioning inside our applicator. We consider a different scenario. We place 5 probes, 1 here in blue in the center of the applicator and 4 in all the cardinal positions. And we also consider different 5 steering targets. Again, 1 in the middle and the other one 5 centimeters in the cardinal positions far from the center. We also consider different axial planes inside the phantom. We consider the center of the phantom and 1 plane above the center and 1 below the center. And these are our results. So on the bottom part of this box plots, we can see the results for the central plane, and on the lower part of the slides for the upper plane and the lower plane. We can see that our errors were well below our thresholds. We had median errors that went from 4% to 6%, confirming also the numerical accuracy for our validation process. So to conclude, and to summarize a bit what I was trying to explain, hyperthermia is more than heat. It helps us in different biological mechanisms, and it is well known as a powerful radiosensitizer and chemosensitizer. Still, it lacks treatment planning systems which are certified and are not currently used in our clinical routine. And that's where HyperPlan comes into place, because it is designed to create a tool which is validated, and it allows to have patient-specific simulations. And this is very important and brings us one step closer to closing this gap, because what do we need as a hospital? It's a safe, reproducible, and certified treatment plan. And thank you for your attention.
Thank you for this very accurate report concerning your measurements and how you did it and how you specified this new treatment planning systems. Have you used it ever in patients now, or is it not allowed for patients?
Not yet.
Not only in the CE process? Do you need patients for the CE processing?
Yes, yes, but it will be a retrospective analysis.
Only with retrospective, okay. Yes. Are there any questions? What about the blood flow? You used phantoms without blood flow?
Without blood flow, no.
Yes, but blood flow is one of the problems of hyperthermia, because blood flow is taking the temperature away.
Yeah.
For example, you have the problem in liver tumors where they have a very high blood flow and it's very difficult to heat them. Can you simulate blood flow in this system?
In this part of the validation process, the blood flow was not included.
Okay.
And so, but of course, it's very interesting for the future, because
yes.
It's very important. I mean, it's also very organ-specific, so it would be interesting to simulate different organs with different blood perfusions.
Mm-hmm. Very interesting point. Okay, then thank you very much for your very interesting report.